Morning, Dr. Alejandro Badia here for yet another bi-weekly episode of the podcast, Fixing Healthcare from the Trenches. And today it's really a pleasure to have somebody who kind of straddles the fence in the clinical and administrative world. So Dr. Peter Jebson is, like myself, an orthopedic hand surgeon. He's extremely well known. I needed some time to go through his CV. I know of his work. We know each other more through recently social media, but he's really in Michigan for many years. Med school, undergrad work, and then more recently was working with as an assistant medical director at an insurance company. And we want to talk a bit. We're gonna focus on that more than sort of your incredible clinical acumen, if you don't mind, Dr. Jebson, because I think that there's a lot of let's just say energy right now around this whole pre-authorization issue amongst clinicians. So first of all, I want to welcome you to the show. Thanks for coming.
Thanks, Alejandro. And I followed your work. Obviously, I commend you and all of your efforts through the healthcare from the trenches. Your passion and your commitment to doing this is commendable.
Thank you. Thank you very much, Peter. As you know, and I'm very candid about this, I think that us physicians, we really need to engage more with this problem. I mean, a lot complain. If you probably remember, going to the surgeon's lounge in a hospital, it used to be discussion of a complicated case, and now the majority of the discussion is what's happening to us. And at some point, we have to engage and do something about it rather than just complain. And what I admire that you have done is you are an associate medical director, assistant medical director at a major insurance carrier. So tell us a little bit about how why you made that jump from being a surgeon to that world.
Yeah. So first of all, obviously, I have to give you the disclaimer that what I'm sharing with you is really my opinion based on my experience as a clinician, also as someone who's been, as you say, on both sides of the fence, so to speak, as a practicing clinician, experiencing the pre-auth process to some degree, also as a department chief and hearing frustrations from colleagues. I practiced for 24 years. I left in 2020 from clinical care administrative duties. I was probably an element of burnout, and I was 57, and I felt that I'd done taking call and the frustrations of healthcare over 25 years had probably taken a little bit of its toll. So I took some time off, and then I was asked by several health insurance companies actually to be in this role. They all of the major insurance carriers have physicians who play a role in the pre-authorization process and in peer-to-peer. And I felt like I still had something to offer and contribute to healthcare. And I wanted to learn more about this process because, as you know, it is a major source of frustration for our colleagues and our patients as well. So that's why I decided to get involved. And I've been doing it now for close to 3 years. It's something I enjoy. I've learned a lot. And I think I can, hopefully during this podcast can share my perspective on this frustrating pre-authorization process.
So what I'm hoping is that certainly the public needs to understand this because they bear the brunt of it, right? I mean, today I saw patients, and I can tell you, the majority of the cases, my hands are being tied with what I'm trying to do clinically. But I think for the physicians listening, they're going to want to love to hear your perspective because, I can tell you that most of the people I've spoken to, what it's a peer-to-peer, so to speak, they're not necessarily peers, right? I mean, you're a peer. Actually, you're somebody I admire in my field. I mean, you're not a hand surgeon. You're actually a big academic hand surgeon. I mean, you've written multiple chapters, authored more than 200 papers. I don't think that's the typical person necessarily working at some of the big insurance carriers. So if you could shed some light on that.
Yeah, well, you're right, and it's actually one of the points that I think is critical in terms of fixing the process is I do believe, again, it's just my personal opinion, that a true peer-to-peer should be a colleague who has familiarity of the clinical condition and can bring to the discussion not only their knowledge of the guidelines, but also their clinical acumen and their experience. I think the peer-to-peer process starts off in a very adversarial fashion when you're not having a true peer-to-peer conversation, when an orthopedic surgeon is having a peer-to-peer conversation with a retired cardiologist or family medicine or intensive. I don't
even, we're both hand surgeons, right? I mean, I think both of us would profess that we don't know much about the cutting edge spine surgery anymore. I mean, we trained 30 years ago. So the peer-to-peer really gets to be that granular. It's got to be really that right subspecialist.
Yeah, I agree. In hand surgery, from a clinical standpoint, the CPT, the authorization for procedural codes, we don't have the same frustrations perhaps as our colleagues who are doing hip and knee arthroplasty or certainly shoulder. We have not experienced that yet. I don't know if it's coming, but the pre-auth process has expanded from subspecialty to subspecialty, and perhaps it's something in the future that our hand colleagues would experience. Hand surgeons who are doing shoulder certainly experience the frustrations of the peer-to-peer process and the pre-authorization process. My opinion is, and the part I enjoy is that I can have a professional conversation with a colleague, try and do the right thing for patient care, and help the colleague who is busy maybe in clinic or between cases, but is certainly busy in their day-to-day life in the clinic, having to document in EMR numerous charts and notes that take up a significant portion of their time. I want to try and help them through the process if it's the right thing to do for their patient care.
So as a involved in a medical director role at these one of these big companies, is I'm hoping that you have the ability to influence that and make sure that if there's a gynecologist, for example, doing some type of procedure, that it's somebody else in that specialty. The problem is you'd have to have a cadre, an army of people to cover most of the specialties, because medicine has gotten so subspecialized, and thank goodness, right? For the public listening, I mean, what we do now, even from 20 years ago, has radically changed. So It's kind of hard to have all these people on dialogue on both sides of the fence, correct?
I agree. And so, for example, the company that I work for, we have about 30 of us. We're all orthopedic surgeons. We've all practiced in different stages. And we don't review spine, and we have clinical guidelines that we follow, but we've all been there to some degree. And so we can have a true conversation. And when, the pre-authorization process, we're reviewing the medical records, and we know what's appropriate based on the guidelines, and we can interpret the notes, the clinician's notes, because we've been there as clinicians. That's a very different conversation than having one with a retired gynecologist, I think, to your point. I personally am not comfortable reviewing a lot of spine cases. That's not been part of my experience. I don't think it's appropriate for me to review those kinds of cases. Those are highly complex. But reviewing general orthopedic cases, shoulder cases, hip and knee arthroplasty is pretty straightforward.
Sure. Okay. So you know what, I want to go back to that, because I have, in terms of my 3 points that I continue to reiterate, I want to touch on what we just talked about. So what I'd like to know now is give us 3 initiatives that you'd like to see enacted that could actually reform U.S. healthcare, that could actually save costs, make it more efficient, make it more pleasant for patients. And make it so that insurance companies can still, be solvent and make money. After all, I tell people I'm a fervent capitalist. I have no problem with an insurance company making money. But, you see what's happening with physicians, right? I mean, we're getting cut every single year.
Yes.
That's why I'm doing it, and so many other people are doing similar podcasts and books, et cetera. So give us your 3 points.
Yeah. So, my 3 points would relate. I have so many points regarding healthcare in general, but as it relates to the pre-authorization process, first of all, I believe in transparency. So I think the process should be transparent. The guidelines, the clinical guidelines should be readily available to every practicing orthopedic surgeon who has to go through the process. The second thing is that I think the guidelines should be built with the input of the American Academy of Orthopedic Surgeons and the specialty societies. using the clinical guidelines. As you know, the American Academy of Orthopedic Surgeons has developed clinical guidelines around several conditions. I think they know why they have to do that. I think it's important, and they are engaged in the process around the pre-authorization process.
So do insurance companies rely on folks like you for their guidelines, or do they use the specialty, whether it be going back to gynecology, the American College of Obstetrics and Gynecology, or the American Academy of Orthopedic Surgeons? Are they using guidelines based upon these specialty societies?
Yes, they are. So that's one of the points that we have when we have a discussion with a physician on peer-to-peer, is we point out that the guidelines are built based on review of the literature, evidence-based, and with the engagement and contributions of the American Academy of Orthopedic Surgeons and the specialty societies. So I can't speak for other companies, Alex, but I can only speak for the company that I am currently employed by, and we do. And those guidelines are revised based upon new evidence, new clinical evidence that comes out. So a new peer-reviewed paper that clearly shows, let's say, a benefit to a procedure, then that will be integrated into the new guidelines. And we revise those guidelines and review them frequently.
Well, I'd like to just let me try to push back on that concept for a moment. When you have guidelines, and they're supposed to be guidelines, right? But one of the beauties of practicing medicine is not just the science of medicine, but the art of medicine. And the art of medicine often it involves people doing a particular procedure that has worked for them. Maybe they've even published in it, but it's not. I don't want to use the word standard of care, because then that opens up a can of worms. But I'm just talking about. I know, for example, myself, we're both hand surgeons. You know, Peter, that I do a lot of basal joint replacement. Right now, it hasn't happened to me, and part of the reason is my practice has been out of network for the past decade. But I would imagine if I was in network, I would be getting a lot of calls from people probably less experienced than you, saying, "Well, that's not the standard, is to do a replacement." Should my innovation and others' colleagues' innovation, and being sometimes ahead of the curve, should that innovation be squashed?
So let me answer that in twofold. First of all, when you and I were training, remember that our mentors and physicians, they were doing knee scopes in arthritic knees and doing the so-called tune-up. We now know that that's not effective with good peer-reviewed literature, right? Right. The second point about the thumb arthroplasty is, I'll be very clear. You and I have had brief discussions around it. I still think that the LRTI works. I think there are problems, however, and I think now there's a growing body of literature around thumb arthroplasty that I think needs to be looked at. And I think the Europeans have been far ahead of that. They have less constraint than we do in those kinds of procedures. And I think— So
that's my point, is that, should we be falling? we're the United States, we're America. Should we be falling behind our colleagues in Europe? And that's what bothers me. That's the core issue here, I think.
So first of all, I don't think we should fall behind Europe. I think the public in the United States deserves the best quality care that they can receive. And I think that the results in the European literature are very encouraging around thumb arthroplasty. Okay. That's certainly not the case with silicone, but contemporary implants are certainly demonstrating some very good results. One of the limitations that we have put on ourselves, so to speak, is the fact that we don't have good high-level clinical evidence on a lot of things that we do. So and that hurts us, because when we have level 4 evidence, it's not quickly adopted.
But I understand the point of view from the insurance company, because they want that. But the fact is, and I hate to, but it's good to have just one example. So I've been doing this for almost 30 years. I've been doing some, I've done basically two implants. Okay, one is not even available. But today I saw post-op. I saw patients I did 48 hours ago. One had the implant and was doing this, and he was amazed because nobody had told him that was available. And then I did an LRTI on somebody who was disappointed to not get the prosthetic. I said, you know what? You have way too much STT arthritis, right? So not to get too technical for our people here, but the point is that I know and I know what has worked for me, and I'm sure that clinicians want to have some degree of that freedom to do what has worked for them. Again, the art of medicine. And I'm just worried that that's going to be stifled by these protocols.
Well, we know that the art of medicine has already been stifled, right? So
yes, okay.
we do know that. But I think
you go to point number 3. I got it. You're right. Thank you, Peter.
Well, I mentioned that the transparency. I think that peer review should be done by true peers, and I think that we need to have better science behind our guidelines. And the one that I encounter a lot, Alex, on peer to peers is, physicians will say to me, "Well, I don't know what code this code is authorized by this company, not authorized by this, and so on." And it's a legitimate source of frustration. Why do we have variations if these are evidence-based guidelines? We should have consistency. They should be applicable across all of the health insurers so that we don't create this frustration for providers and patients that if I change my insurance, this is now good after the first of the year, but it's not good now. I think we should be transparent and consistent across all health insurance carriers.
I love that. Well, I'm happy to report that today we were gathering further data on this thumb prosthesis, and several other clinicians who do it around the country we're putting that together. So I agree. It's just that in the end, it kind of brings me to my first point. So I'm going to give my first point now in the interest of time. And I've been saying this for a long time, is I do think we need oversight, right? But I would like to see oversight, not authorization. So there's a difference. The difference is kind of like, TSA starting to do. You don't need to pass everybody through a scanner because we'd all miss our flights, right? Yeah. So little by little. So once we've been vetted, I mean, I know your training, okay? I know mine. I know many of my colleagues. Why, when insurance companies allow, having me see one of their patients, why don't they just say, unless you're doing something crazy, we want to do oversight. Why does each step of the way require a little number or a long number to do it? And that's what's hog-tying us. And that actually paradoxically increases the cost of healthcare.
Agreed.
Because there's a ton of people sitting in offices doing that. And I think that's the part that we could really minimize. And we need oversight, right? Because there are bad apples, there's overutilizers, I make mistakes. What's your thought on that?
Yeah, so let me respond to the bad apples comment first, and then I'll come back to that. I don't think we have a lot of bad apples in orthopedics. The vast majority of issues that I see are poor documentation, which is understandable today's healthcare. The oversight comment is appropriate. I think the process can be improved without having to authorize every procedure. If you and I have to be careful what I say, but there are procedures in place to do that exact vetting process, which let's just take Dr. Padilla, for example. Dr. Padilla does shoulders, and all of his last 6 months rotator cuff requests have been appropriate. They follow the guidelines. Well, anytime now in the future that Dr. Padilla submits a CPT code for rotator cuff, that should be automatically authorized. And then there can be an auditing process to down the road to make sure that overall it's a more efficient process. And by the way,
so an auditing process, exactly. But let me take the step further. When I see that patient, I examine them, and I don't order MRIs on every single person. Right? Yeah. Today, I saw somebody that clearly had a bicipital tendonitis. We talked about conservative treatment. Said, if you're not getting better, I'd like to determine, but I'm going to have to get an authorization potentially for that patient. And then if I decide to do therapy, say no surgery, therapy, I have to get therapy authorized. What I'm trying to say is, don't I have enough expertise as an upper limb specialist who hasn't touched the knee or a spine in 30 years, that once they're approved to see me, let me do what I know how to do without these interferences.
Yes.
But audit me. I agree.
Yes.
See the difference?
Yes. And I know the difference, and I completely agree with you. And that process is in place now with some healthcare carriers where they are granting certain groups, certain healthcare systems that pass, if you will, and then on the backside are looking at cases and auditing to make sure that everything is aligned. So,
and wouldn't that save them money? Because there's an army of people out there that, I know my girls are, thank God they don't do it that much anymore, but they're on the phone, put on hold, waiting to get this silly number. In the end, I think that insurance company could use that money a little bit more wisely, rather than having somebody who's got, a salary, benefits, including health insurance, ironically, right? All of those things cost money.
Yeah, no question that, ultimately what I'd like to see personally is that money passed back to the consumer, right? With lower cost premiums. You are absolutely right that medical practices, individuals like yourself, I was in private practice with a colleague for 3 years. And while we didn't have a lot of pre-auth, we still had to get auth for surgical cases and certain insurance plans and for MRIs, to your point. It costs, the data is out there that it costs orthopedic offices and physicians in general a significant amount of money to have pre-auth specialists in their office. And that process, I think the whole process needs to be improved. I tell you, one of the cutting edge topics that's out there is the potential role of AI in this process.
Sure,
and
absolutely.
I think it will play a role in the future.
That's wonderful. Well, so that brings me to my second point, right? So I said oversight, not authorization. The second one, which also saves money for the insurance carrier, and this has been frustrating because my journey, which is now going to be almost a decade and a half with Ortho Now. I believe seeing the right specialist at the right time saves a lot of money. Not to mention the aggravation to the patient. But my God, I didn't order an MRI today on that shoulder. I think many of my primary care colleagues probably would. They're overworked. They're trying to keep us healthy. They're dealing with us systemically, and all of a sudden, a shoulder pain patient comes in. Of course, they order an MRI because they're like that. It's going to spit out a diagnosis. They're not going to look at the imaging study. I really doubt they will. So have the right specialist see that patient at the right time, meaning before things get worse, before it becomes a massive cuff tear. That is something I think that we should work towards.
Completely agree. As you know, I copied your Ortho Now, if you will, as a department chief, where in our own department, we put in a form of an urgent care. And as you and I both know, this is becoming very popular around the country. It improves access. It gets you to the right people. And then the right tests are ordered, or the right treatment is rendered.
Exactly. That's a great point.
And I completely agree with you on that point.
Right. No, very little MRIs right on tennis elbow. I mean, my God, right?
Completely agree.
Yeah.
Agree.
So wonderful. So those things tie into my third, which is exactly what we're doing, Peter. And I thank you so much, Dr. Jebson, for joining us. Public education. And you know what? I'm going to go on a limb and make a comment here because people are very, politically correct. But I'm going to say, in healthcare, when is the public going to reach that I can't breathe moment? Right. We saw incredible societal changes because of some bad cops. Okay. And, and that those issues don't affect 20% of our economy. So the question is, when are people going to take as much interest? I don't know. Having you on, Peter, we might be able to rival Joe Rogan, but if we could get the engagement and the views, this and so many other podcasts that are out there about healthcare, if we could get the public really interested in this, right? And that's why we try to keep this to about 20 minutes. That's the goal.
I personally think that we're getting close to a tipping point, Alex. If you look at the percentage of money that individuals and families are spending on copays and deductibles, that curve has gone like this, where it is not sustainable. It's not sustainable for individuals or families, and something has to change. The insurers want skin in the game. They want us as patients to have skin in the game. I get that. But the amount of money that individuals are spending on healthcare premiums, copays, deductibles is unsurmountable. We're putting many people in medical debt, and there's no other country in the world like it. And we're not getting value. So what we are paying for, we're not getting value when you look at data on
all the markers.
Yeah.
Well, I had Senator Dr. Bill Cassidy, Senator of Louisiana, who's a gastroenterologist, and he rightly, he goes, Alejandro, I need to push back on that about the markers, because there's certain there are certain caveats that influence those numbers. So we don't have time to go into that, but no question that what's happening is, yes, the curve is this way for cost for patients, and the problem is the curve is this way going down for the clinicians. 3 of the 4 hand surgeons that I have a company that does some implants, and 3 of the 4 of them are no longer doing hand surgery. And I think that's very sad. And I think the public is going to really get to that moment when they realize they're having trouble finding, and that's already happening.
Yeah, you're absolutely right. So access will be a problem, and it's really multifactorial. We're going to have a projected shortage of orthopedic surgeons. You've seen an expansion in some of the residency programs, but it is not going to answer the crisis. We've seen access issues where those that are practicing are working extra hard, and they're working extra hard with declining reimbursements. All of these variables are going to reach a critical point, and where you're seeing physicians stepping away from clinical care, no longer accepting particular insurances, not able to respond to their patients' phone calls or needs. We're not delivering value. The system is really not a good system for patient care.
Well, I want to comment on that. I went out of network after, I put in my, 20 years being in network, seeing, I've seen contracts 60% of Medicare. The public, I don't think quite understands that. But the point being is that I want to be able to give my patients the time. And I'll tell you, I'm really enjoying doing hand and upper limb surgery now. I see a lot less patients I used to. I can spend a lot of time with them. And, for the most part, being reimbursed. I shouldn't say that word anymore. I like to say paid. Reimbursed means somebody's paying me back for money I laid out. I think that's a bad word that we continue to use as doctors. So I'm not being reimbursed. I'm being paid for the work I do. And you made a great point there, that a lot are leaving, and I'm hoping that we can reverse that. So, discussions like this hopefully will mean something. Hopefully people will share this. That's more important than, liking it, share it, talk about it, push back, tell Dr. Jebson and myself that we're wrong. I don't care. That means you're showing interest. So I'll give you the last word, Peter.
Well, I think it's great that you're doing this, and you're right. Public awareness is important. I don't think the public is aware of the impending crisis. It's bad enough now, but it's going to get worse. And the question of opting out of certain networks, it's only a matter of time, frankly, before we start to see concierge orthopedic surgery, where we can actually do cases, truly practice our craft, give good patient care, good communication, time for our patients, and feel like we're being paid for our services. It's happening in other specialties, just a matter of time before it starts to become something in orthopedics.
That's true, but not everybody can afford that, and as a society. But I'm thinking that if we can make healthcare more efficiently, that's why I talk about the authorization, that we can save enough money. There'll actually be more money to put into that safety net, because I think in every society we need to be able to take care of everyone.
I agree,
and hopefully, if we can save money, we'll be able to do that. So excellent. Okay, well, thank you, Dr. Jebson, for joining us. Until 2 weeks from now. Please again talk about what we went over today on purpose. Once Dr. Jebson started giving us his perspective in the health insurance industry, I thought we needed to just keep going. So apologize to those who we ran a bit over. Hopefully you're listening to us driving to work or in the gym, and I kept you on the treadmill a little longer. So see you in 2 weeks. Signing off from Fixing Healthcare from the Trenches. Thank you all.
Thanks, Alex.